Good evening. Thanks for joining us tonight for this special program, moving toward ending the HIV epidemic. And this is a focus on the South, particularly. So those of you who are joining from the South, welcome. For those who are not, welcome to our world. So I'm David Wall, and I am at the University of North Carolina in Chapel Hill in the Division of Infectious Diseases, and my disclosures are there. And I'm really excited to be joined tonight by Dr. Lance Okeke, and I'll have him introduce himself.
Yeah, good evening, everyone. I'm Lance Okeke, and I'm an assistant professor of medicine here at Duke University School of Medicine, just down the road from David in Durham, North Carolina. My disclosures are below.
Thanks, Lance. And Dr. Okeke and I have worked together quite a bit, and I'm just, again, really excited that he's here. He has a great perspective and lots of experience. This is CME, which is great, and here's our objectives, and you can see them there, but we'll go through it all. And we'll start out in different sections, and again, it's going to be a little bit of a game of tennis, and I'll pitch the ball back to Lance and him back to me, and that way we try to keep it a little bit interesting, hopefully really interesting. So first, we're going to talk about ending this epidemic, the OG pandemic, HIV, which we've been dealing with for a really long time. But we've made really great strides. And I had to check on the data in this slide to make sure it was correct. And it remarkably is. So remember 90, 90, 90? That's at the bottom here. In 2020, 84% of people in the world, 38 million people living with HIV, 84% know their status. Not 90, but pretty close, not too bad. Could be a lot worse. We could do a little better. And about 87% of those are on treatment. And 91% of those are virologically suppressed. So we've got 84, 87, 91 instead of 90, 90, 90, but we're getting there, which is fantastic. Our goals for 2030 are 95, 95, 95. So we're upping the ante. So this is exciting. This is something we have to work harder on. Certainly COVID-19 probably is going to throw some curves into this, and we may have to catch up, but we've got some years to do it. And I think this is really impressive. And there's a lot we could talk about. We could spend a tremendous amount of time on this slide talking about how this happened, the motivation, the political will, the unification. There was not a lot of controversy of we need to get people on HIV therapy. No one thought, at that point that HIV was made up or that the medicines were going to hurt them. They realized that this was a revolution and we had to make it available for people all over the world. A little bit different than the current pandemic. So when we look at the United States, though, we still do have some gaps here that we can address very, very, very locally for us. These are stark data. And if you don't know these data, this will be surprising to you. So, 53% of people who were diagnosed with HIV back in 2019, that's over 35,000 people, half of them were in the South. Now, the South is, it's including Texas and Florida, so some populous states, but this is where HIV is. So it's not up north. It's not in, in the coast where you're going to find the most HIV. You're going to find it here in our neck of the woods. And importantly, a large proportion of people, 13%, unacceptably high, don't know that they are HIV infected. And this is extrapolated data from the CDC. And you can see the states where this is more common. Again, predominantly, but not only in the South, but certainly the southern half of the United States, but the Southeast as well. So Dr. Okeke, myself, his colleague and mine, Dr. McKellar over at Duke, have thought hard about, well, what makes the South different? What distinguishes the South and the southern HIV epidemic from the epidemic that's occurring in other parts of our country? And so we've highlighted some of them here. I think you can add your own, and certainly this is worthy of a lot of commentary, but certainly poverty. We have the highest poverty rate and the lowest median household income compared to the other regions of the country. 31% of people in the South live in poverty, compared to 20% or so in other parts of the world, of the country. We can talk a long time about racism and about institutional and structural and systemic racism, especially here in the South. We could talk about homophobia. And while that and racism and poverty and all these things exist all over the country, there are some differences here. We can see this reflected in some of the laws. And laws can have impact, and they set a tone. And so the greatest proportion of states that have either no hate crime law or no law protecting LGBTQ, that's in the South. There's access barriers, again, all over the country, but particularly here in the South, where we have many people who live in rural and semi-rural areas. So nearly half of people in America who are without health insurance live in the South. And not too surprisingly, as we all know, more states in the South than any other region have not expanded Medicaid or embraced Obamacare. Limited transportation, limited service providers, all these things conspire to make access harder for people living with HIV in the southern part of the country compared to others. There is a lot of stigma. There's a lot we could talk about with Southern culture, with religiosity, all these types of things that factor in. The other one that's really important is mass incarceration. Again, this is a nationwide problem, but states that incarcerate more of their population are located in the South and disproportionately do so of people of color, again, more so in the South. And this does have an impact on HIV transmission in communities that are blighted both by poverty, racism, homophobia, access problems, and also mass incarceration, especially of young men of color in their communities. So we could think about, how do we put this all together and where do we move from here? And this is a rubric for doing so. And this is a framework that we can use a little bit to think about, like, well, how do we make this difference? How do we get to where we want to achieve, especially here in our part of the country where we have all these challenges? A lot of it does start with screening and testing and awareness of HIV. And that could lead HIV negative folks. So you're testing negative, you're not done. We can link people to preventive services. There's more and more that we know how to do to prevent people from getting infected. But it takes being aware of this, screening, testing, then talking to people, taking a sexual history in a really nice way, in a way that isn't confrontational or judgmental, and then discussing with people ways that they can protect themselves, whether they be men, women, cis, trans, whatever. I think we have to find out more about this as part of our general health screening. So those of you who are primary care docs, find effective, innovative, comfortable ways to talk about sexual health as part of general health in your practice, and you will learn a lot. Certainly, many people come in asking for erectile dysfunction drugs. They're not afraid to talk to you about sex. And I think this is the time when we have to flip it around and talk to people about their sexual health to keep them safe. Certainly, if people are HIV infected, a well-trodden path from diagnosis to getting linked to a healthcare provider who could provide antiretroviral therapy as soon as possible, someone who knows what they're doing, who is comfortable with people living with HIV infection and vice versa, get people on therapy and keep them on a therapy that's going to be workable for them, that's going to be sustainable, and get their viral load undetectable and to keep it undetectable. So there's a lot there. We can unpackage this as we go through the rest of our evening, but this is, I think, a framework that we should all incorporate no matter what kind of practices we are involved with. So the last thing I'll say is, before I turn it over to Dr. Okeke, is, again, this is a really amazing slide. And one thing that we're going to talk a little bit about in about 12 slides is maybe there's a fourth 90 or a fourth 95%, and that's living well with HIV. The fruits of all this labor are people are living longer with HIV. If your viral load is suppressed, your life expectancy is starting to approximate those who are not HIV infected. That means people are living longer and they're getting to be older. And so we have to think as well, not just about the duration of survival, but the quality of life. So not just life expectancy, but life quality. That's another thing that we'll come back to as we think about especially some of the challenges in the South vis-a-vis some of the epidemic obesity, stroke, cardiovascular disease, diabetes, that, we have here disproportionate to other parts of the country. So Dr. Okeke, I'm going to turn this back over to you.
Thank you, Dr. Wall. So thank you again for having me this evening. Over the next few slides, we're going to go over some of the comorbidities that kind of really address that improving the quality of life of persons living with HIV and aging well with HIV, as Dr. Wall alluded to. And so our hope, and of course this could be like a semester's full of lecture here. However, our hope is over the next 45 minutes or so that we can actually get a very broad survey of like the pertinent issues to persons living with HIV and aging well with HIV going forward, and what we can do as providers to kind of facilitate that process to the best of our ability. So I think this is a really important study in that it was from the Kaiser Santa Clara group and the Kaiser Permanente group, in which they looked back at the average life expectancy at age 21 for a really, really large cohort. So basically, in this case, it was 420,000 individuals, 387,000 without HIV and 39,000 with HIV. And they looked to see what was the expected life expectancy from age 21, added years of life going forward from the age of 21. And what they found was that when you compare persons without HIV to persons with HIV, persons living with HIV on average had a life expectancy 9 years shorter than the rest of the population of persons without HIV. And it's a surprise to me looking at this study again. I looked at it back when it came out, but looking at it again, that the expectations that you would think that, okay, well, if we start antiretroviral therapies earlier with a robust CD4 count and without the HIV-induced immunosuppression and all the secondary havoc it creates for end organ dysfunction, that maybe we can actually close that gap significantly. And the fact is, yes, it does close the gap, but it only closes the gap from 9 years to 7 years. So not completely, not even close. And then you look at comorbidity-free years, and yes, again, you can see the difference between the two groups. In persons living with HIV, overall, 16 years less of comorbidity-free survival compared to the rest of the population. And you can see the breakdown of the figure to the right for each different condition. And of course, starting antiretrovirals early with CD4 count greater than 500 narrows that gap in some of the comorbidities, but nowhere close to baseline for the uninfected population. And so something really to consider. And so the goal of everything that we talk about here is to see how we can actually, in our individual patient, from person to person, start to close that gap, hopefully, but at least at the very minimum, give the best quality of life that we can to our patients. So this is a really interesting modeling study from the NA Accord cohort. And so this is one of the biggest clinical cohorts in the country. And what it looked at was the distribution of persons on antiretrovirals nationwide and number of comorbidities per age subset. So there's lots of different dimensions going on here, but I'll try to walk you through the best that I can. So the projected number of persons living with on ART by 2030, 928,000 nationwide. The persons living with 2 or more physical comorbidities is projected to increase from 30 to 36% during that period. Now, I want to really point your attention to the bottom panel from ages 50 to 60 and 60 to 70, because if you look at where we are right now, the red represents 2 or more comorbidities, and you can see the distribution of comorbidities across time. We're right here at 2021, and you can see that we're essentially at the leading edge of a silver tsunami, the wave of not just aging, but associated comorbidity. And that in the conversation that we're having right now is very, very timely in terms of how we address and how we manage comorbidities as our patients become more complex in terms of their needs for chronic medical care. And so realize this is the leading edge of that. And the knowledge that we can actually impart on each other during this time period is probably more important than ever as our patient population ages going forward in the next 5 to 10 years. Now, looking at the issue of polypharmacy specifically, the green arrow, the light green arrow represents persons with HIV, and the darker green arrow, teal, and I'm probably a little partially colorblind, is mostly persons without HIV. Now, this is a study looking at Medicare claims from 60,000 individuals, looking at the prevalence of polypharmacy in persons with HIV versus persons not living with HIV. The definition of polypharmacy means persons on greater than 5 non-antiretroviral agents at the time of observation, so greater than 5. And you can see that on the x-axis, divided by age group, divided by gender, female and male, and you can see that in every age group across the board, persons living with HIV are more likely to have be defined as having polypharmacy all across the board than persons without HIV. Of course, for me, what was most striking is looking at that age group between the ages of 18 and 39 to see that the prevalence of polypharmacy in that group was upwards of 60% in persons with HIV, in women with HIV, and 56% in men with males with HIV. Those are really, really high numbers for what you consider a relatively young and relatively healthy age group. So something to consider. But overall, 76% in persons with HIV versus 61% in persons without HIV. The difference between the two groups is clear in terms of the increased prevalence of polypharmacy in this population. Now, looking at the VAX cohort, so now looking at again, the prevalence of polypharmacy and its downstream implications. And so looking at what happens if there's a linear relationship between hospitalization and mortality based on the degree of polypharmacy. And what this study shows us, which is from the VAX cohort, looking at over 48,000 persons within that cohort, that the more the higher the degree of polypharmacy, the increased rates of hospitalization, increased rates of mortality. And those thresholds 2 and 5 are arbitrary, but there's a clear linear relationship between like how severe your polypharmacy is and how you fare as regards to hospitalization and mortality. And if you look at in this cohort of persons with HIV, that there's even a steeper jump in terms of like the degree of polypharmacy and your risk for mortality within the next few years from the time of observation. And so again, increased levels of polypharmacy, but also increased hospitalization and mortality as a result. Now, I think for those of us that are in the South, there's no surprise to us that we have a lot of superimposed epidemics here in our region. Not just the epidemic of HIV, as Dr. Wall very eloquently alluded to or articulated in the presentation. 50, of course, I have to remind you that figure again because it's important. 53% of all new infections live in 50 of all new infections within the United States occur in the South in 2019. That's more than half. Now, if you look at that directly is superimposed with the concentration of cardiovascular disease in the country. Again, higher prevalences of obesity, higher prevalences of high blood pressure, higher prevalence of diabetes. This is not just the HIV belt, unfortunately, it's also the heart attack belt and everything else. And so we have our work cut out for us as Southern providers in this current state of affairs. One thing I did want to talk about is really the downstream effects of that metabolic dysfunction and liver disease. But before I do that, I think I have a couple of questions coming about the polypharmacy I want to kind of go ahead and integrate. So the first question, I'm just reading off the board, so I apologize, is a polypharmacy, so this is going back to our polypharmacy section, due to their antiretroviral therapy or comorbidities? And I think it's a really good question. And the answer to that is that in both of those studies, antiretroviral therapy was accounted for. And so it wasn't counted in the number of agents that were used to make that definition. Just looking specifically at non-antiretroviral prescriptions in that population. Comorbidities is probably the answer. And so there's debate about the degree of like the most common comorbidities and the prevalence of the most common comorbidities in persons living with HIV versus those without. But we do know that for many comorbidities across the board, persons with HIV, there's a higher prevalence amongst persons with HIV than without. So looking at things like obesity, looking at hypertension, hyperlipidemia. And so as a result, that may explain that increase or at least step up in polypharmacy compared to the uninfected population. I want to look at one more question about polypharmacy. So does that mean that they go to multiple pharmacies or they go on many drugs? And I think the simple answer to that question is they're on many drugs. Whether it be that they're getting them from different pharmacies or not, I don't think that the study was addressing that. The question is, from wherever the source was, there are more prescriptions than the rest of the population. And so moving on to liver dysfunction and non-alcoholic fatty liver disease. So looking at the number of persons on and the prevalence of non-alcoholic fatty liver disease in the general population, again, it's about 30%. So there's probably some underdetection going on here because as you know, as providers, you're oftentimes surprised when you get a serendipitous, you have the serendipitous finding of hepatic steatosis for a CT scan that's obtained for some other reason. And like, oh, by the way, they have fat in their liver. Whether it meets the 5% threshold or not, oftentimes is not quantified in that context, but it's there and it's there quite commonly. But the spectrum of non-alcoholic fatty liver disease, of course, is divided really into two. And it's non-alcoholic fatty liver and non-alcoholic steatohepatitis, or NASH, basically. I'll refer to them as NAFL and NASH going forward, just for ease of conversation. And of course, about between 1 in 10 or 1 in 5 persons with NAFL will have real, true NASH. So basically, fatty infiltration with evidence of hepatic inflammation. And it's really tempting to say, okay, well, steatohepatitis, fatty liver steatosis plus increase in transaminases equals NASH. But that's actually not the case. And you actually have to do your work to actually exclude other causes of hepatitis before that declaration of NASH can be made. So it's truly a diagnosis of exclusion. And looking at within the dimension of persons living with HIV, so stratifying between HIV and not HIV, of course, the prevalence in the two groups is about the same. So there's no definitive evidence that persons living with HIV are at higher risk for NAFLD. But that's still really an area of evolution of which we're trying to kind of like figure out for sure. The risk factors are the same across the board. Of course, there's the added risk of what is the attributable risk of antiretroviral therapy, but also the fact that NAFL is actually observed in persons of lower BMI amongst persons living with HIV. Looking at the topic of NASH, so 25 to 30% of all persons have NASH within the general population. The 25-30% of persons, with NAFLD have NASH. A little high, depending on what estimates you look at. Really, based on the study you look at, that range goes from 10% to 45%. We always kind of settle somewhere in between the 25 to 30 range. But also, there's evidence that perhaps a higher proportion of people with NAFLD and HIV actually do have true NASH. And so that's still in evolution, but there's a suggestion at least that if you have NAFLD and you have HIV, that there's a higher chance that you actually will have, or at least progress to NASH than than HIV uninfected persons. Of course, there's fibrosis progression as well. And we're still trying to figure that out, and long-term outcomes are still too early to tell, but there are definitely groups looking into how those outcomes are divergent between persons living with HIV chronically and persons that are uninfected. Now, again, as I was alluding to earlier, NAFLD is a diagnosis of exclusion. NASH is a diagnosis of exclusion. You can't really make that diagnosis until you've actually gone through the machinations of actually ruling out other causes for hepatitis. So it's not just steatosis and elevated liver enzymes equals NASH or NAFLD. It's really saying that I know that there's nothing else going on, especially with alcohol intake. And so you have to go through that. But once you do, then it's really important to really kind of distinguish, if you can, between NAFLD and NASH. And that's where the indications for liver biopsy come into play. Now, there is no consensus on who exactly with NAFLD should proceed to liver biopsy. I think everyone knows here that oftentimes these are radiographic diagnoses. However, there are a few indications, including a significant liver enzyme elevation, higher risk for advanced fibrosis based on laboratory values, and the fact that you can't rule out other diseases. So you want to make sure you have a histopathologic diagnosis and make sure it is NASH and not anything else, or at least in the process of trying to diagnose another disease. Now, of course, you have the list here. This is basic internal medicine 101. All the other causes of hepatitis apart from NASH. But once again, the point is, once you've ruled those out, then you can start to really entertain that diagnosis and use that to kind of guide your management going forward. So I think the general thought is, I think is the frustrating part about discussing NAFLD is it's a dynamic process, and there are no drugs as of November 3rd, 2021 to treat NAFLD. There's no silver bullet. It's really lifestyle modifications, labor of love. It's behavioral change. It's really sticking with the tried and true modifiable risk factors and managing them aggressively, and always kind of sticking with that conversation of longitudinal healthy living with all of your patients until that magic bullet comes. And even after it comes, quite frankly, we should be promoting modifiable risk factors and how to modify them in their direction. And so, of course, non-modifiable risk factors are what they are, and I actually tend not to spend too much time on those because they're static. They are what they are, and you can't do much about them. Now, I think going into the treatment of obesity, I'm not going to spend too much time on this slide because, again, this could be like a semester or a year's worth of lecture here. But I think the point of this slide is truly that weight loss is a key, and weight loss is multifactorial. Weight loss and actually addressing other risk factors for cardiovascular disease, and in the process, losing weight. And so always considering, what you're doing to treat diabetes and like how you're treating your hyperlipidemia, general counseling for obesity, and it's really pleiotropic effects on all the other comorbid conditions that you're treating as well. Of course, the dietary modifiers, of course, alcohol cessation, smoking cessation, coffee consumption, and its effect on liver health. All of those are clear. But again, the common denominator is really trying to modify those risk factors going to the metabolic syndrome and seeing, unfortunately, liver disease either abrogate as a result of it, or at least progress slower than it otherwise would once you address those risk factors. So again, it seems like a whole bunch of fluffy talk, but truly, this is the only solution to this public health condition and its prevalence that we have in NAFL. Again, 30% of the population, but the solution is tried and true. And so I'm going to pass it on to Dr. Wells to talk a little bit more about frailty. I think this is a really fascinating area of increased research, especially within the HIV space right now. And I'll be interested to hear his comments on this space.
Yeah, no, thank you, Lance. This is great. And I think the inclusion of NAFL and NASH was really important because I don't think we spend as much time talking about that and some of the other things we are talking about, cardiovascular disease, frailty, bone health that we'll cover today. Oftentimes liver health gets not as much attention as it should, and the prevalence you just shared with us, I think, is key. And certainly is something that I think I have to think a little bit more about as well. Another challenge for us in the South is it's not so easy just to have your Metro Pass and go to radiology and get your ultrasound. Our folks have to drive back to see us and also to get their tests done. So I find that that's another obstacle. Maybe we'll talk a little bit about that when we talk about DEXA scans. I am going to talk just very briefly about frailty. Frailty is, I think, of all the things we do talk about, I think it's somewhat of an all-encompassing concept. Whether we talk about polypharmacy, people are on medications, as Lance said, for a reason, because they have comorbidities. And comorbidities stack. And when they stack, people generally are less healthy. And we've seen that again through the prism of the COVID pandemic, where those who have comorbidities don't fare as well. Same thing happens with HIV, of course, under a different sort of cadence and timeline. But we do know that people living with HIV do accumulate comorbidities and other conditions that can lead to them to not be as healthy as they could be. And so we're going to talk about the concept, theoretical concept of frailty, a framework for thinking about this, and some of the data. And we do know that people living with HIV, not necessarily all because of their HIV, and that there's a retrovirus that, has, integrated with inside of our genome, and it's not our antiretrovirals necessarily, but it's complicated, and it may have to do with the lives that people who are at risk for HIV and people who do get infected with HIV live. And there's a lot of the things we talked about on that other slide, whether it be the stress of living with homophobia or racism or aggressive policing or poverty and food insecurity. Those things take a toll. And I think we all know that they do one way or another. And biologically, in biochemistry, we know also it takes its toll. So what do we know about people living with HIV and this concept of frailty? Well, if you use a standard definition of frailty and pre-frailty that I'll go over in a second, that's widely used, and you compare people living with HIV to people not living with HIV, you do find across the spectrum of older age and middle age that there are more people who qualify for pre-frailty and frailty who are HIV positive than those who aren't HIV positive. Again, for a confluence of reasons. People could smoke more, do drugs more, have tougher lives, could be their HIV therapy or their HIV, all of the above. But we do know that there's more inflammation, there's more immunosenescence, there's more changes in metabolism, maybe mitochondrial dysfunction, but maybe, just other things like we talked about, mental health, addiction, that also can play into this, poverty. This study is the AIDS HIV study. It comes from the Netherlands, but it's replicating data that we've seen. If anything, it's only worse here in the United States. So what are we talking about when we talk about frailty? It's one of those things, it's a word that most of us think we know what it means, but there are actual concepts or frameworks where this is defined. This is one of them. It's one of the most popular because it's been around for a while, since at least the 70s. But I'll tell you, it's one of those that are a little bit hard to operationalize. And it's a sensitive method for detecting frailty, but it's not very, I think, clinically applicable. There are other screens that we can use that get at the same thing. But the general idea is that there's a spectrum going from being robust, which is just a great term. Every one of us wants to be robust. You look robust, I look robust, Lance looks robust. That's great. Pre-frailty is, I may not look so robust, but I'm not, in a situation where you would say I would be frail. That may be that you have reduced muscle strength or low energy. You get kind of winded easily, but you can do your stuff. You're not frail. Frail is when we start to get 3 or more criteria, and you can see them kind of listed here, but we're talking about some of those same things: unintentional weight loss, low energy, slow walking speed, poor grip, exhaustion, can't get out of a chair without using the armrest to get yourself up. These are the kind of things that we look for and that geriatricians can spot a mile away. And those are the things that we see much more commonly in people who are HIV infected. And as I showed you on the previous slide, it happens at a younger age. So younger people with HIV meet more qualifications for frailty than people who are without HIV who are older. And that's why this whole concept of accelerated aging, which I don't think is exactly what's happening, is that there's more things happening to people at a younger age who are HIV positive that generally happen to older people. Again, for complicated reasons, both probably biological and also, if you will, structural, environmental. Back to that same cohort from the Netherlands, when they looked at frailty and pre-frailty and mortality over time, no surprise, it tracks very nicely. I'm sure if they added on polypharmacy, it would look the same, just like Lance showed before, that these are surrogate markers for risk for death. And so if you're frail, you're much more likely, and this is not a long time span, this is going on for 6 years of follow-up. You can see that a large proportion of people who qualified as frail died. And again, not all of them were elderly. Okay, so this is something that we see in people who are on HIV therapy and people not on HIV therapy. It's probably worse in people who are not on HIV therapy. Pre-frailty, which is a little bit harder to diagnose. Remember, you only have to have like 1 or 2 of those criteria, which, on a bad day, many people can have. So this has to be persistent. They also started to have an increased risk. And a lot of those people progressed to frailty over time. So you can switch categories. As we'll talk about, you can also switch the other way. You can go from pre-frail to robust, and even sometimes from frail to pre-frail, and maybe even exceptionally to robust. So this is looking at all comers. Most of them were on HIV therapy. So this is 96% for a cumulative 10 years. So Noella asked, is this frailty state prior to ART? No, not necessarily. This is happening to people with suppressed viremia. We see this all the time. This helps also explain the important data that Lance showed us from the Kaiser Permanente group. That 7 to 9 year difference in people's mortality, whether they were HIV positive or not. This plays into it. And again, it's complicated. And people who are like the investigators here and others who take a deep dive into this find many different reasons. How do you correct for HIV infection in ART when more people with HIV smoke or have smoked or have had closed head injuries or, have had, severe weight loss in their past or have been exposed more to corticosteroids? There's all these confounders, but it's the constellation of them, regardless of the mechanism, that leads to the evidence that we're seeing here of increased risk for frailty. Sarcopenia is probably one of the most important underlying mechanisms of frailty, and that makes sense. If our bodies are not working, if they don't do the things we want them to do to attend to the activities that we need to do to stay healthy, then you can't be robust. And people with living with HIV do suffer from more sarcopenia. Strictly speaking, this is loss of muscle. There's a great graphic that a colleague of ours, Todd Brown from Johns Hopkins, shows, which we should probably steal, but it shows CT scans of the thigh of 4 different people. And one of them is a 46-year-old runner. And then you get to, a 70-year-old frail person. And what you see is, instead of looking like a T-bone steak, what you see is very little striated muscle, but a lot of subcutaneous tissue. So it almost looks like a donut instead of looking like a steak. But then he shows us 2 other CT scans, one from a farmer who's like 76, and he looks like the 46-year-old, right? And so I think those are the kind of things that we have to think about, and I try to think about for myself and my patients, is you want to be able to get out of a chair. You want to be able to get up off the floor if you fall down. That takes muscle. And people with HIV infection, for a variety of different reasons, whether it be now probably mostly obesity that keeps them from being able to exercise, or the wear and tear that we see very commonly in people who've led tough lives, it makes it hard for them to exercise. It makes it hard for them not to have atrophy of their muscular system. We do know, just like Lance said, and this is going to be the mantra, for motivated people, if you want to start losing fat in your liver, if you want to start building back muscle into your limbs, you have to do some physical activity. Physical activity makes a huge difference for many of the comorbidities we're talking about. It's not always an option for everyone to join a gym, especially nowadays. Probably not a good idea to join a gym right this moment or afford to go to the Y. Not everyone can walk in their neighborhood, but many can. And there's lots of things people can do just in their own living room to keep themselves fit, to get their heart rate up, to get their muscles moving. And that's kind of the thing that I try to talk to my patients about. You don't have to buy an elliptical. If you can just bend over, if you can do squats, if you can do some push-ups or sit-ups, there's little things you can do that can make a big difference. And we can ratchet that up over time. So again, just like Lance said about, NAFL and NASH, there's no magic bullet. There's no medicine or a shot that we can give to someone to say, we're not going to have you be frail. It's a structured approach. And more we're borrowing from the geriatricians and looking at this holistically. So can we do something exercise-wise? Even just something modest like I just described. Let's look at your diet, because diet has a lot to do with everything we're talking about as well. And we don't have to do anything very special. And you don't have to buy powders. You don't have to join a special program that costs money per month. We just have to make some good choices based upon what's available to you. We talked about polypharmacy. Something that I try to look through is what medications are people on and see if we could get them on a lower dose or get them off of it. Again, that's really key because these things accumulate and these polypharmacy issues end up leading to polytoxicity. Big problem for a lot of my patients is that they fall and they're unsteady on their feet, especially if they have that sarcopenia phenotype. So we work on what we can do to build up some of that strength and make their homes safer. Cognitive disorders and mood disorders are really key to this as well. And that's, again, like Lance said, that's worthy of a whole nother session. It's hard to be motivated if you don't feel good about yourself, if you feel depressed and apathetic. It's a vicious cycle, though, that could be reversed the other way, because the more you exercise, the more you do, and the more physical activity you get, the better your mood is. But sometimes we need to kickstart it by addressing some of the depression, some of the anxiety, some of the cognitive impairment, the sleep disorders. This can help our patients get onto more steady level footing to start actually doing some of these non-pharmacological interventions. I'm going to turn it back over to Lance for this, and this is related to talk about bone health.
Thank you, David. And so, I love what I love amongst many things that David said was talking about that de-escalation of medication. So I think you think about it, we have multiple roles, multiple tasks to complete in a very short period of time as primary care physicians in the cases that we are for persons living with HIV. But one of the most important roles that you can actually accomplish during that time, during that 30-minute visit, and if you take even 10 minutes to do it, it's really, really important, is just medication reconciliation. Beyond what your nurse or medical assistant does, just sitting down and taking part of a visit and saying, okay, what are you on? Do you really need this? Let's go one by one to figure out what's happening here. I think is very, very underestimated as a tool for providers. And I think that's why I loved it, the fact that David brought it up, because I think the simple things oftentimes make a huge, huge difference. So moving on to bone health, and it's kind of as a corollary to kind of a frailty, the frame, the skeleton structure of movement and kind of like dynamicity for the human body and what happens to it as a result of chronic HIV infection. I love this graph here, looking at projections on bone loss and the fact that really, in no matter what, HIV infection itself and chronic antiretroviral therapy actually are independent risk factors for accelerated bone loss. I think most people on the call know that there are antiretroviral agents that are really kind of implicated in this, specifically tenofovir, proxil fumarate. But in general, it's more complicated than that. But we know for a fact on a population level that the acceleration in bone density loss in persons living with HIV is unequivocal. So for those reasons, some of you may have seen the most recent guidelines for primary care for persons living with HIV. These aren't really new recommendations, quite frankly, and that this more aggressive approach to pursuing bone mineral density surveillance is actually something that's existed for a long, long time. Now, of course, how it actually manifests in practice is a different story. So, the recommendations currently are for DEXAs for all postmenopausal women and men over the age of 50. Now, if you compare that to persons not living with HIV, so the general guidelines by the USPSTF, it's really women over the age of 65 or postmenopausal women with clinical risk factors for osteopenia, and then men over the age of 70. So this is a significant divergence from what's recommended for the unaffected population. Now, of course, only if the DEXA scans show evidence of osteopenia do you actually go forward to vitamin D screening to look for serum on vitamin D levels, calcium levels, and consideration of bisphosphonate for those T-scores between -1 and -2.5. But it should only be measured for persons with documented osteopenia or osteoporosis. Of course, screening for a transgender persons should follow national recommendations based upon their sex at birth and individualized based on risk for osteoporosis. And so I think that's really important to consider. Now, the question is, do you order DEXA scans on all your persons living with HIV? I know for a fact that from a practicality standpoint, again, and David alluded to this earlier in the talk, in terms of linking the folks that you see within clinic with a reliable radiology infrastructure to make sure they all get their DEXA scans. In the South, it's a little bit difficult. It's not about going on a metro stop two stops down the line and saying, hey, here's a radiology place, go. It's a lot more different. You have to drive oftentimes miles to get to a good radiologist to actually do these. And scheduling becomes difficult as a result. And so how do we implement this approach within the Southern context? I think it's an open area for discussion and one that we should think about. But I think, at least in our practice, the first step is really establishing those relationships with radiology sections of your institution or your clinic or whatever, your referral network to say, hey, if we're to do this right, we need to have a reliable pathway for getting DEXA scans. We want to make sure you guys can handle the extra volume of persons we're going to send you as a result of our more kind of stringent guidelines for who should be presented for DEXA scans going forward. And so I think I'm interested to think about in terms of an implementation strategy, implementation issue that should be considered going forward and potentially one that's incorporated into your local practices. So let's see here. So I think you can look at the trabeculations here, and I think everyone knows about the T-score, 1 to 2.5, being classified as osteopenia, anything over 2.5, and you start to go into frank osteoporosis. And the key here is looking at the trabeculations of the bone, very dense in the top panel, as you would expect a normal a bone of normal density, increased porosity in the middle panel, and with some micro cracks if you look at the matrices themselves of the bones. And then the actual separation of the trabecula in the third panel, really, really important. And that's where you start to have lots of structural integrity and a decrease in the ability of the bone to kind of like bear that stress capacity, increased risk of fracture structurally as a result. I have a lot of questions coming here, so I want to go ahead and see if I can incorporate a few of them. So I think joining she's going to be part of frailty phenotype. Oh, sorry, that's David's. Looking at this question here from Noella. So screening for vitamin D is not recommended for all races. Blacks almost always have vitamin D deficiency and insufficiency. And yeah, so I think that goes back to what we were saying in that universal screening for vitamin D is not recommended. And that's one of many reasons why we don't recommend that for everybody across the board. But I think it's a really, really important point to figure out. Now, of course, you can't consider bone mineral density without looking at the co-localizing conditions and the exacerbating conditions that contribute to bone health. And so here's a long list here. Of course, some of these are in terms of like relative risk, persons living with HIV versus without, higher prevalence of persons living with HIV. So from hypogonadal states, which is more well documented, persons with HIV have having a higher prevalence. Other endocrine disorders like adrenal insufficiency, malabsorption, hematologic disorders like sickle cell, pulmonary diseases like emphysema, alcohol intake and excessive alcohol intake, and then other conditions like chronic infection, chronic kidney disease, vitamin D deficiency, and of course medications, including tenofovir, proxafumarate, amongst others that are associated with accelerated bone loss over time. And so we have to consider all of those in terms of like how we look at the bone health in persons with HIV, and that it's not really a monolithic condition, and that it's one that is really an end manifestation of a lot of extrinsic factors that contribute to like bone mineral density loss over time and accelerated BMD loss in persons with HIV. Now, looking at this study from the HOPS cohort, 17 years worth of data, and looking at incident fractures and mortality in persons living with HIV and fractures. And if you look at the right-sided figure, the incidence rate over time of persons living with HIV and fractures has actually decreased, because when you look at more robust immune systems as a result, the incidence rate of death in persons with fracture actually decreases. And so you're looking at a person with, in general, better protoplasm overall. And that's probably what explains these decreased rates. Protoplasm from an immune reconstitution standpoint, protoplasm from the antiretrovirals that they're exposed to over time, protoplasm from the fact that we actually catch folks earlier and treat earlier. And as a result, they never suffer any of the longstanding deleterious effects of HIV-induced immunosuppression or HIV-induced severe immunosuppression. So, but even with that rate of mortality is actually really, really high in persons with fractures and HIV. And if you look at it, compared to the general population, HIV was an incident fracture was an independent risk factor for all-cause mortality. 45% increase amongst persons living with HIV of all-cause mortality for persons who have incident fractures versus persons who didn't. You can see the other comorbidities on the side: chronic renal disease, HIV, hepatitis C co-infection. But looking at the independent association of fracture, 45% increased risk of mortality during the follow-up period for this study. It's a large study of 7,000 people. So think about that as a risk factor. You're having pathologic fractures or fractures as a result of decreased bone mineral density. And you should think about that and the long-term effects of kind of trying to steer that ship back in the right direction in terms of long-term management. Now, of course, this is just a repeat of the prior data, but framed in another way. Looking retrospectively at a large cohort within VAX, 80,000 individuals, and you can see that persons living with HIV are at higher risk for total fractures, for hip fractures for risk fractures compared to the persons living without HIV. And we're not talking about 1,000 or 2,000 people. This is 80,000 people. And you see these prevalence rates almost double in terms of like total fractures, osteopenic fractures in that population. When you look at everything all told and you adjust for all appropriate covariates, HIV itself was associated with a 40% increase of relative risk for fracture compared to persons living with HIV. So again, HIV as an independent risk factor for incident fractures in this population. And so with that, it all again goes back to justifying why we're a little bit more aggressive in bone mineral density surveillance, or at least we should be in persons with HIV than in the general population. Now, so it's a lot of information, but one thing I love about algorithms is that they're really kind of like right in your face and really kind of take into consideration many different clinical scenarios and in a very streamlined way, give you actionable items to figure out what to do next. And so a synthesis of everything that we've said and everything that we've observed with bone health persons with HIV is here on this really, really nice figure. And so you think about it, the two populations that we talked about earlier, so men over the age of 50, but also all postmenopausal women, regardless of clinical risk. If you have HIV and you fit in one of those two clinical groups, you should get a DEXA scan. Now, of course, you do the DEXA scan, and then it becomes very similar to just the general population, in that persons with osteopenia should have a FRAX score calculated. If their 10-year FRAX score is greater than 20%, then you consider bisphosphonates, vitamin D supplementation, and calcium supplementation as well. If their FRAX score is obviously less than negative 2.5, then you consider, first of all, secondary causes, but at the same time also, if there's no identifiable secondary cause, then you actually look for bisphosphonate and other treatments, vitamin D supplementation, calcium supplementation, to kind of help with bone mineral density. But again, those bins are the same. T-scores of -1, just watch every 2 to 5 years, -1 to -2.5, consider treatment for the right population, especially if their FRAX scores are elevated. And then -2.5 or more, look for secondary causes to make sure you're not missing anything. And then in most individuals, you go ahead and move on with treatment with bisphosphonates, your bisphosphonate of choice going forward. With more frequent monitoring, 1 to 2 years in this case, if you know that they have clear evidence of bone mineral density loss that's accelerated or severe. And of course, TDF, anyone with osteoporosis and really, quite frankly, osteopenia, you really should be looking for another drug. And I think if I were to guess, the prevalence of TDF use amongst our providers on this call has probably dropped off significantly with the availability of TAF. But of course, just a reiteration of the fact that TDF is associated with accelerated bone mineral density loss. And if you have anyone that has any risk factors for accelerated BMD loss or hyperaccelerated, then you should really consider another agent, including TAF or whatever base regimens that you prefer. And so, of course, we live in 2021, so there are many options. But think about that when you're kind of looking at some of these TDF-based regimens that still kind of persist in contemporary times. Think about the effects on bone health going forward. And so I'm just going to do a quick overview of like the things you know already. And here, the reason why we've packed them into a single slide is because a lot of these things are the same in regardless of who you're seeing, regardless of HIV serostatus, but really should be reinforced in persons living with HIV. So stop smoking cessation is key and really is prime in many cases. Can't say that enough. It sounds rote, but it's really important. The nuts and bolts of prostate, breast, lung, and colon cancer screening. Again, pap smears, 3 consecutive, and after 3 consecutive negatives, Q3-year follow-up. Anal cancer screening is a dynamic area with the results of the anchor study and all that. And so I think that's really a TBD. I know in our practice, we don't have as well as ideal of an access to high resolution endoscopy as say in David's practice, for example. So I think that's something to consider, but we should be expanding anal cancer screening for sure. And we should have the right personnel to kind of do that. And I think the quicker we can move towards that, and the fact that the evidence has shown definitively that there's benefit and mortality benefit with that, the better we are in terms of actually getting with the times and and really promoting anal cancer screening as part of routine primary care persons with HIV. And of course, hepatocellular screening in the appropriate populations. And then, of course, a key about A1c monitoring. And so remember, the thresholds to be worried for diabetes and prediabetes in persons with HIV are generally lower. So instead of looking at 6.5, really 6.1, 6.2, 6.3 in someone living with HIV, because of the underestimation of the percentage of glycated hemoglobin in persons with HIV, you should really look at that threshold of 6.5 and lower it a little bit in persons with HIV going forward. I have to continue to remind myself of this, but it's a really nuanced but a very important point in that we can be missing early diabetes in a number of our individuals living with HIV if we rely just on the A1c. So always remember that and make that part of your practice as well. So we're gonna pivot quite a bit here to long-acting injectables, and spend the last few minutes on what to do with long-actings and implementation of these really innovative agents going forward.
Yeah, no, thank you. And we'll do this pretty quickly. I know that there are a couple of lingering questions that I think we could knock out pretty quickly. Karen asked about frailty, and what about people who have bad knees or bad joints who can't get up without using handrails and stuff? Well, I think that can contribute to frailty for sure. And sometimes that's a consequence of osteoarthritis, which could lead to people having a greater risk of frailty, as we see with people who, as they get older. But not everyone who is handicapped is frail. And certainly there's folks who may not be able to use their legs or have joint issues, but otherwise don't meet any other criteria. And those are people who are doing everything they can despite that disability. So no, I don't think that necessarily qualifies you as frail. It's got to be part of the whole complex. So that might be also able to explain things. Someone else asked about over-the-counter medicines. It's Noella again, about over-the-counter medicines and supplements, and do they count as polypharmacy? A lot of the studies we're talking about that look at polypharmacy look at pharmacy records. So they don't have an all-knowing, they don't have a uvula cam, so we don't know exactly what people are swallowing. So they have to look at some records, and generally they're looking at pharmacy records that don't reflect a lot of these. So if anything, this is an underestimate of what people are taking. So we're going to move, and that kind of segues really quickly to just a couple of overview slides about long-acting injectables, because I think this is a really important topic. So whether you know it or not, and many of us know it really well because this is front and center, long-acting injectable cabotegravir and rilpivirine as a treatment for HIV infection was approved by the FDA in January of 2021. There were a lot of other things happening in January of 2021, including a surge of the pandemic, transition of power here in the United States, lots going on. So a lot of folks didn't hear about this or know about, but now you do know about it if you didn't. This is approved. It's not experimental. We have it right now. The issue is, as we'll talk about in about 30 seconds, it's not so easy. This is injected. It's injected in the hip. So if you put your hands on your hip, like you're, scolding a teenager, right below where your hands are is pretty much where this is injected in the gluteus medius muscle. It's indicated for people who have suppressed virus on oral therapy first, and it's given every month right now. Okay, so this is what we should know. 2 different injections, one for rilpivirine, one for cabotegravir. There's a bunch of things that we know about this combination because there's been some really great clinical trials in which people have entered the study on older medicines or were treatment naive and induced into virologic suppression and then put on the long-acting injectable. But we do know that failure can occur and failure with resistance can occur, albeit rarely. And some of the factors that have been identified in the clinical trials are listed here. Having a big BMI, maybe because the injection and where the depot is delivered may not be perfectly adequate for absorption for some people who are bigger. And then also this really weird thing of this baseline HIV subtype called A or A6 or A1. This is a subtype of HIV that we don't have much here, but is located in Europe, especially in Russia, Eastern Europe and Russia. And some of the clinical trials were done in those areas. And so some of the failure that was seen, if not the majority in some of the studies, was in that part of the world where that subtype, for one reason or another, just doesn't seem to respond as well as the subtype we have here. The last thing that makes a lot of sense is that if you have some baseline resistance, especially to rilpivirine, lower barrier to resistance for rilpivirine than other drugs, then it's less likely to work. And some people do have that because that could be transmitted when people get infected or cultivated if people have been on other NNRTIs. Having the dosings manipulated with some adjustment of the amount of drug that's injected in some of the clinical trials, looking at every 8-week dosing instead of every 4-week dosing, that wasn't associated with failure. And so we may see that in the future. This may be an every 2-month administered drug. I'm not going to talk about all the stuff on here, but implementing this is a challenge. And recognizing that, the manufacturers of this medication started to do some implementation science, understanding a little bit more about the demonstrating whether or not this could be done in clinics. 5 different clinic types across 8 cities were pilot testing using long-acting injectables in their clinic. For those of you who are not doing it, just imagining how you're going to find people, where you're going to inject people, are you going to store the drug, how are you going to track people to make sure they come back every 4 weeks, because there's not a lot of leeway around that 4 weeks. That's a lot of work. And while people had a lot of concerns early on, some of that was mitigated once they started doing it, but it still was a work burden, and if you will, an unfunded work burden at that. So it does take work. It takes dedicated hours. It takes some staff time. And many of us, I don't know about you, Lance, and what's going on down, up the road, but here we're still, I joke, in the contemplation phase of how we're going to do this, not in the action phase. So this is still something we're planning. In this demonstration project, the drug was given to them. Procuring the drug is not that easy. There's some steps you have to go through, and certainly some prior authorization. So again, not something that most of us have a lot of experience with. I think this will get better over time, but it's out there. And for some of our patients, this is a big deal. Some of our patients really, it's not the majority, but some significant minority could benefit from long-acting injectables. These are people who come to their clinic appointments, whether they take their medicines really well or not, they need to be suppressed. But being on a long-acting injectable, not having to take a pill every day that reminds you have HIV infection, not having to hide your pill bottles, there's all sorts of potential benefits. You know it when you see it. When someone says, I would love to get rid of my pills, I'm willing to take injections. Those are the people we enrolled in the clinical trial and have been on long-acting injectable for years. So that's it. We're only 3 minutes over, which is not too bad given the content that we covered. I think that's it. All right, Lance, any final words?
No final words at all. Thank you, David. And thank you for the opportunity to kind of talk about this really kind of a dynamic process of, again, increasing the quality of life for our really beloved patients living with HIV. And we do the best we can by them, but there's a lot to do and a lot to learn. And so to the extent that we can become the better primary care providers that will benefit us all immensely as we go forward in taking care of our patients the best way we know how.
Perfect. Thank you.